So this is a schematic diagram of actual colon cancer. So on the left side of the image, pointer, no? Okay. So at this side here, you can actually see that the bowel wall, so this here is bowel, intestine, and the wall there is thickened. So those are the features that we're looking for on the CT scan. So we have there bowel wall thickening. We also have small lymph nodes around, and then we'll also use the CT to look for liver metastases and peritoneal deposits. Next slide. Now, this is the gold standard of rectal cancer imaging. And why is it ideal for rectal cancer? MRI has the advantage over CT in that it shows us very, very clear images of the rectum. You can actually, so the image on the right, you can see 1, 2, 3. So those are basically the 3 layers of the rectum. You won't see this on CT scan. So depending on which part of the rectum is involved, you can actually now stage the tumor. So if it's 1 or 2 or 3, each of those things have different meanings. And then you also have, you can precisely say which part of the pelvis is involved. So SV there is the seminal vesicles. The R is the rectum. The 2 arrows basically point to something called the mesorectal fascia. Then you can also see lymph nodes. So based on which part of all this is involved, it lets the surgeon know, okay, if I go in and I do a resection, am I going to get something called an R0? So an R0 means that there is no tumor left, more or less. And that is the goal, really, for any surgery. So based on which part is involved, they can say, okay, this patient needs to have chemo before surgery. This patient needs to have radiotherapy before surgery. That is the advantage of MRI. Next slide. So I talked about PET earlier. And PET is just like CT, but then the only difference is that you are giving a radioactive sugar into the body. And the whole premise of that is that cancerous cells, because they're dividing so fast, right, they consume a lot of sugar. So when you give that radioactive sugar, it basically lights up. And that's what we see on the CT scan. So even areas that are really, really small and you're not sure, oh, is this a metastasis? Is it a lymph node? Is it fibrosis from surgery? With the PET CT, all that is basically clarified. So I talked earlier about the ultrasound and the CT colonography. So the endorectal ultrasound, it's basically a really thin probe, something we call very high frequency, that can also show us the walls of the mucosa, of the rectum rather, but we can only use it for T1 and T2 tumors. The abdominal ultrasound scan really just to look for liver metastasis. You can't really tell us much more about that. But one of the advantages is that it can be done at the bedside. Virtual colonoscopy, it has benefits, especially in patients who are unfit. But the gold standard that most surgeons will recommend is a colonoscopy, because they can take their biopsies or remove the polyps at one sitting. Because if you send a patient for a CT colonography and there actually is an abnormality, the patient is still going to have to come back again to have a regular colonoscopy and the abnormality taken care of. Next slide, please. So when we talk about staging, that's another area where the radiology comes in, really, is we want to tell the clinician, how far has this tumor spread? Because that is basically the bedrock of what's going to determine the treatment decisions for the patients. So the TNM staging, that's the universal language. I know that some specialties like O&G have some other things they use like FIGO and all those things. But TNM, that's what every oncologist uses. So T talks about how deep the tumor has gone. N talks about how many lymph nodes are basically affected. And then M, how far has the tumor spread? Next slide. Okay, so this is a schematic diagram that basically shows, can we reduce the... So when we say a tumor is T1, we're saying that it's just in the submucosal layer. That's the very first layer of the rectum. If we're saying that tumor is T2, it's gone into something called the muscularis propria. If we're saying it's T3, it's gone into the mesorectum. T4 tumors are tumors that have invaded the mesorectal fascia. So the next slide, next slide, please. So these are images of what these cancers actually look like. So the TIS is what they call in situ. So those are the very, 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 very early stage. That's the stage anybody would want their colon cancer to be picked. Because at this stage, you're almost going to get cured. Now the T1, like I said earlier, is just within the submucosal layer. Then the T2 is a tumor that, is within the muscularis propria. Now the muscularis propria is this very dark line that we see. It's like a circle. So that's the outer wall of the rectum. Now once the tumor has breached that and gone into the perirectal fat, this bright area here, now that is a T3 tumor. Now there's something we call the mesorectal fascia, and the mesorectal fascia is basically like the boundary of the rectum. So this thin line is a dark line that we see on MRI, and the degree of how much of that is involved is also very important. So which is why I have something called T3 MRF negative, T3 MRF positive, because all these things have surgical implications. Okay. Next slide. So why do we want to stage? The more advanced your cancer is, the lesser the degree of survival. So at stage 4, 13%, at stage 1, 92%, which is the reason why early detection is extremely important. So this just speaks to why we screen or how we screen. Now, there's no hard or fast rule. So that's why there are different risk categories. And depending on whether you are deemed average risk, moderate, or high risk, that determines what the recommended action is going to be. So are you getting a colonoscopy every 5 years? Or are you getting a colonoscopy every year? Do you need to have prophylactic surgery? Or, just you do your FIT test every 2 years? So when you get your radiology report, it's going to contain a lot of information. So we are talking about how long the tumor is, how far the tumor is from the anorectal junction, how far it is from the outermost aspect of the anal canal, which we call the inner verge. What's the relationship to the peritoneum? What's the morphology of the tumor? And how far is it spread into the fat? How far is it spread into the surrounding organs? Is there venous invasion? Are there tumor deposits? All this information is basically included in the radiology reports, because all of this is very, very key information to the surgeon. So if the report does not contain any of this, it's not complete. So there are a lot of plenty English in our radiology reports that may not make sense if you're looking at the report as a clinician. What are they saying about circumferential margin? What's all this? So circumferential margin basically is how far the tumor is from, I mentioned earlier about the MRF. So if the tumor is 1 millimeter or less from the MRF, that means that there's a very high risk that patient is going to have recurrence. Is the peritoneum involved? If yes, prognosis worsens. Is there extramural venous vascular invasion? So that means the bowel, the blood vessels outside of the bowel, are they involved? If yes, then there's a higher risk. Is there a mucinous tumor? Or even after treatment, all of this information is very, very important. Which is why I said earlier on the previous slide is that your radiology report that is going to the managing clinician, or if you're sending your patient out for referral, after you've sent the patient for the MRI, has to have all that information in it. Next slide. So when the patient comes to us, what is the imaging journey? So you've done the screening, Dr. Sita has done colonoscopy, they've found something, they've diagnosed, they've done biopsy, result has come back out. Then we go to staging. We want to do the chest, abdomen, and pelvis. If it's a rectal tumor, plus a rectal MRI. No rectal cancer imaging is complete if the patient has not had an MRI. And then the MDT review. So MDT is basically all the clinicians that are involved in the management of that patient. So the surgeon, the colorectal surgeon, the radiologist, the oncologist, everybody sitting down and discussing, looking at the images and talking about a treatment plan. We have the full complement of all the specialists at Iwosan, Lagoon Hospital, and I think that's one of the advantages of a multidisciplinary center, because really no cancer management cancer management really is incomplete if there's no MDT review. And then obviously the treatment, response, surveillance, and then surveillance. Next slide. So what are the key takeaways? CT is the workhouse for staging. It's fast, it's available, and it detects distant spread. MRI is mandatory for rectal cancer, and it defines the surgical margins and local stage better than any other test. Now, the stage at diagnosis is the most important prediction of survival. So the later the cancer is picked up, the poorer the prognosis. PET-CT is not routine for all patients. It just adds value. And there are key things that you should look out for when you get your patient's radiology report. And then obviously, I talked about the MDT, which on its own is very, very important. Next slide. Okay, so thank you, everyone. Okay.
Thank you, Dr. Fumilayo James. I am already considering looking into the radiology residency after this presentation. Thank you so much. All right, so we'd like to recognize the presence, or rather, I want to recognize our colleagues that are joining us virtually, YouTube and Teams. We see you. And also, while we're listening to those beautiful presentation, some of our distinguished colleagues to join us into into the ceremony, and I'd like to recognize their presence. The Managing Director, Iwosan Lagoon Hospital, Idejo, no other person than Dr. Oluwatomi Kogo. And also the Managing Director of Iwosan Lagoon Hospital, Ikeja, Dr. Oluyemisi Odubayo. Please put your hands together. All right, so I just want to say something. While I was seated there, I was thinking, after listening to Dr. Osita present, he said something that caught my attention. He said, once you turn 40, you should do a colonoscopy. I started thinking, this is serious. Because 40 is coming, and that means they have to put something in my bum. You know, it's really tough, because when we say these things, we don't go through them. We just say, do a digital rectal. They did a digital rectal examination on me, on myself. I realized that this thing is really very uncomfortable. You know, do a DRE, why don't you do it? So we think about it, we should do it, we should encourage ourselves, we should actually attempt it. So I'm worried and I'm thinking about it. Anyways, so we're going on a very short break. Let's put something in our tummy, something very light, not like fufu and all those other things, but something very light. So ladies and gentlemen, let's go for a short break and we'll be back. All right, thank you. So please, we can just step outside, you know, to get some of the light appetizers waiting for us. Don't be shy, be free. We can do it in an orderly manner, table by table, or
Welcome back, everybody, from that much needed short break. Okay, I would wait for us to settle down. Permit me to guide us into the second part of this doctors forum. I would like to start by recognizing our colleagues who are joining us virtually via Teams and YouTube.
We see you. Thank you.
I would also love to recognize a senior colleague representing Dr. Ngozi Onya, MD of Pelon Memorial Hospital. We have Dr. Talabi.
Please put your hands together.
He is the Chief Medical Officer and in-house General Surgeon of Pelon Memorial Hospital. Lovely to meet you.
Thank you for joining us. Sir. All right. Once upon a time, the human hand defined the limits of surgery. Today, precision has a new partner. In the fight against colorectal cancer, robotics has stepped in. Not to replace us, but to steady our hands, extend our vision, and redefine our outcomes. Today we explore not just disease, but progress. Not just treatment, but transformation. Ogochukwu, please.
On that note, I would love to welcome on stage the reason why we are here, the visiting colorectal cancer expert, Dr. Akinfemi.
Please put your hands together for him. Sir, I want you to still remain seated, please. But please put your hands together for him. Please put your hands together for Dr. Akinfemi, please. Fantastic. All right, so let us know Dr. Akinfemi a little bit. Let's just have a brief.
Can we have his citation, please?
The profile, please.
His profile, thank you.
Yes. Yes, I think the profile is causing technical issues. Do you want to read it?
Okay. Dr. Akinfemi Akingboye is a consultant robotic laparoscopic colorectal general surgeon at Iwosan Lagoon Hospital. He is also a National Institute for Health and Care Research scholar, a senior clinical lecturer at Aston Medical School, Birmingham, and an associate professor of surgery at St. George's University School of Medicine, Grenada. He earned his MBBS from the College of Medicine, University of Ibadan. I'm sorry.
Please. It is Ibadan, not Lagos, please.
Please no disrespect University of Ibadan. And is a fellow of the Royal College of Surgeons of England. He holds a Doctor of Medicine degree from Queen Mary University of London, reflecting a strong academic and research foundation.
with extensive expertise in minimal invasive and robotic surgery. Dr. Akingboye is committed to delivering evidence-based and patient-centered care. His practice combines advanced surgical technology with active involvement in research and surgical training, ensuring patients benefit from modern techniques and continually improving standards. He is also the founder of the TOSOL Impact Initiative, a non-governmental organization dedicated to providing free healthcare services to undeserved communities across Africa. Ladies and gentlemen, without further ado, Dr. Ogochukwu.
I would like to welcome on stage Dr.
Mr. Akinfemi. Please put your hands together for our surgeon, please. Thank you.
Thank you, everybody. Good afternoon. Ladies and gentlemen. I'd like to thank the organizing hospital, the Iwosan Lagoon Hospital, particularly Mr. Fumilayo. I was going to say Dr. Fumilayo. Thank you so much. Fola Lawi, right? Folashade Lawi, is that correct? And also the other executive, Dr. Oyeniro and the other executive all protocol observed. Sorry, I'm not a camera person. Can we have the light down so I can? Most of the things I'll be saying this afternoon has been said already. I just want to make a bit of emphasis on surgery, making it applicable in our community. That'll be my main emphasis. Okay, next slide. So I'm gonna go over a few of the overviews. I go epidemiology. I'll look at epidemiology of cancer, risk factors, anatomical distribution, staging, mentioned already by Dr. James. Management. I'll talk about that later. And the spread, and also inner cancer, to make a distinction between colorectal cancer and inner cancer. And then I'll look at prevention. So okay. Colorectal cancer, like we know, is the third most commonest cancer after breast cancer and after prostate cancer. And believe you me, is actually the foremost cause of mortality in the worldwide now. So it's fast spreading. So what we used to say in the past was when I was in medical school 30 years ago, we don't have in Africa. It's not true. The sad thing is that the trend we now see in Africa, particularly West Africa, Nigeria, we now see more trend in the young. And I'll talk about later. The incidence is about more in the Western world. So in Nigeria we say roughly about 4 per 100,000. So you can imagine the number. Yes, earlier on it said that men and women are almost of the same incidence, but we know that male factor has more capacity because men smoke and alcohol is higher. Women are trying to catch up as well in smoking and drinking. I'm not sure about here. And the median age is about 40, 45. In African, in Caucasian, it's said to be elderly. Of the elderly. In Nigeria and the West African population, we see more young population. Next slide, please. I mentioned that. So risk factors. So polyps. So yesterday we had a lady. For something-year-old lady. She had a big polyp which I had to remove endoscopically yesterday for her. And so polyp to me is actually the main precursor for colorectal cancer. And the whole idea of screening, we're talking about screening, is to pick early. So if you pick a polyp, you remove it. Cancer rates to almost zero. So once the polyp is dealt with, then getting cancer is reduced. The different polyps, but the most common polyp is tubercular adenoma that we know that can predispose to colorectal cancer. Other comorbidities. When I was in medical school as well, we don't have it in Africa. It's not true. So we're now seeing incidents of inflammatory bowel disease is actually on the rise. And UC, which is ulcerative colitis, and Crohn's disease are actually major precursors. Tend to present with diarrhea. Typical hospital with diarrhea, blood in their stool. nothing is done. That should be watched out for. Other things, like Dr. Stab mentioned earlier, previous surgeries, bypass surgeries. What they do basically, they increase instead of balancing malabsorption is when you move somebody's TI, the terminal island. What happens is the terminal island deals with the bile acid, and once the bile acid is not dealt with, you get bile acid going to the colon, and that's the part of how we get colon cancer. We also have immunosuppression and so on. Transplants on the rise now. People having kidney transplants. Should be on the watch out for cancer. Diabetes, we know is also all the major risk factors in our society that we know is obesity, smoking and processed meat, smoke fish. I've been implicated in colorectal cancer. Now I'm going to talk about the genomics. So genomics of all the colorectal cancer, only 3% of them is genetically inclined. When we're in medical school, I don't know medical school, we don't have taught medical school, we don't have in Africa. It's not true. So we now have Lynch syndrome, FAP, non-polyposis coli, and they're all genetically inclined. So the lesson here is that if you have a relative who have been treated with colorectal cancer, ask them for the biological behavior of the cancer, because they're different behaviors. The biology will tell us whether the family need to be screened. There's no point in you having your surgery done and then your cousins or your siblings are left untreated, or your father left untreated. So that's the key thing. It's not all cancer. It's a very small portion. But bear in mind that if you have a cancer done, you must oncology pathologies report, like Dr. James was saying earlier. Pathology is very important for you to tell is this cancer hereditary. If it's hereditary, then you'll be on the more closer surveillance. That's the key message. Next slide, please. Okay, next slide, please. This is all being dealt with. I'm not going to bore you with all the details about this. The key thing to talk about is FOBs, FITs. Now, the screening program in the UK where I work is that once you reach 50 years of age, they start sending you samples for you to get his 2 sample tests. And if you find some blood in your stool, now what we then do is that it now becomes quantifiable. So in the past we do FOBT, just you say it's +1, +2, but now the FITs, I believe you have FIT in Iwosan. So FITs can be done, and that can quantify the number of the red cells that are possible in the stool. And once that's been quantified, once more than 10, you're qualified to have a colonoscopy. Is that right? Yeah. The other thing to say is that colonoscopy is the gold standard. We mentioned it could be invasive, but I've had one done. So that's social media. I know people have on this table have some done. So colonoscopy is important. Once you reach my age, I'm quite young. Once you reach my age, you need to have a colonoscopy. And it's more like an MOT. So it gives you kind of reassurance that the mucosa is stable, and that will then put your mind to rest for the next 5 years. And then you have to do it again. Because the reason to do it again is because you're always constantly exposed for a matter of fact you cannot control. And you need to do it again. And you need to do it again. The other thing to say here is that colonoscopy was mentioned earlier on. So if somebody's elderly and they're unable to, or they're claustrophobic, or somebody trying to put something in your back passage, they have other issues, then we recommend CT colonoscopy as a substitute. I haven't said that if you find that you have a polyp, then you still have a colonoscopy, because you must diagnose what it is. Okay. And I said about syndromics, you need average. If you're family, you got a family history of somebody's got colorectal cancer, then you need to have it done. Now what we actually encourage is that because in Africa people don't have the genomic understanding yet. So if somebody in your family has colorectal cancer under your 50, it's highly likely that the person may have a genomic component. Does that make sense? So therefore you need to actively seek your own surveillance. Because the person may not have gone to the right places, and they may have probably not done the genetic screening. So we don't know, and if we don't know, and the person is young, then we assume, even in the UK, we assume that could be some genetic component, and then you need to have a surveillance. Because there are too many more markers to test for. There's so many of them. I don't want to go into details of that. So let's bear that in mind. I'm just trying to keep salient points, take home message. Family member, less than 50 years of age, with colorectal cancer, please seek help. Next slide, please. So I'm just going to look at the anatomy of the colon. So the colon is divided into 3 parts. 4 parts. You have the right side of the colon, the left side of the colon, and the left side of the colon, and the rectum and the anus. Look at this diagram very clearly. The interesting thing is that The cecum, which is a part that's close to the appendix, is 14% on its own. It's 14% on its own. And the trouble with that is that the cecum is very capacious. It's very large. Things can sit down there. Things can sit down there, and nothing. You won't do anything, and it could be there for a long time. And it could be there for a long time. Number two is that on the left hand side here, you see the sigmoid colon, rectosigmoid colon, and the rectum. If you add them together, that's 54%. That accounts for the majority of the colon cancer. And aims to blood in this two is very important. Now the trouble with this side of the colon, which is mentioned earlier on, is that it's very capacious. It can go up to about 10 centimeters in size. That means that you can have insidious blood loss, so gradual blood loss, minimal blood loss over time, and that will give you what they call iron deficiency anemia. Now the issue with that is that in the past, again, when I was in medical school many years ago, they'll tell you, in Africa, anemia is due to poor nutrition. It's not true. Somebody's got anemia, and they've got weight loss of some degree. Check them out. Now the other issue about weight loss is that because we're all trying to be more health conscious, so people tend to lose weight, and you cannot tell where they're losing weight. So be aware. So be aware. Next slide. So that's next slide. So that's emphasis over there. Now back to the issue of teamwork. So teamwork makes the dream work. So that's my team there. I was doing my robotic surgery there. I've got a lot of people in the room. That's not about me. That's not about me. The key thing to emphasize here is MDT. Now the MDT is multidisciplinary meeting where a lot of specialty come together to decide the course of action for how to best deliver treatment for a particular cancer. And the MDT naturally will consist of a pathologist who can understand the cell biology. Radiologists. Nurses are very important. They're so important because they are the patient advocates. You don't see them. You don't see them. All their worries go to the nurses. We got an airline to call when you have cancer. That's what we should be thinking of developing here in Nigeria as well. Nurses who can. Thank you for the marker. So we have nurses who are purely trained to look after colorectal cancer, and that's their job. And they provide the helpline to speak to the patient. Even after I've done my surgery, they are the ones who cover them. You look after their stoma for them. So they need to think of how to develop nurses with special interest in cancer. And I'm sure that should be in the pipeline in Nigeria. Furthermore, we have medical oncologists, and they are the experts who then look at all the combination of drugs. What chemotherapy is better? You have immunotherapy, you have chemo, radiation oncology. Those are the job. I put here advanced endoscopists. So people who can do endoscopy. Sometimes it's quite challenging to do endoscopy. Some polyps can be removed endoscopically. Anesthetists are very important. So I have what complex surgery anesthetists because I do complex surgery. So they are part of our MDT. They help us to determine because most of the cancer we see in England, they're quite elderly. So they're over 70, and they have multiple comorbidities. So to manage them effectively, people who can understand how to help them make a decision. Some can say no, surgery is not the best for you. Palliative conversation. That's very difficult conversation to have. And you need somebody who's trained to do that as well. And I said input from liver surgeon. We know that most colorectal cancer will primarily spread to the liver, and the reason is because of the venous system circulation. So what that means is that the portal system, all of the blood flow in the body will drain first to the liver before going anywhere else, and the cancer cell will follow the same pathway. So hence the liver is more fully culprit. So your MDT is advisable for you to have somebody who knows about the liver, who can tell you options. Liver force or colorectal force and all of that. And the last one I said here is access to advanced colorectal person. I don't do peritoneal cancer, and I don't do advanced for obvious reasons. But the advanced person is that sometimes, like Dr. James mentioned about, I'll show you the slides there. Talked about beyond the TME, CMR. So sometimes the cancer is gone to other organs. It's gone to the prostate gland. It's gone to the bladder. That means you leave them to die. So that's the rule of that. That's the rule of the advanced colorectal surgery and multipulmonary approach to doing that. Yeah, next slide, please. Again, I won't bore you about this because she's already mentioned it clearly. I'm going to just emphasize that the bowel. So cancer can be going T1, T2, T3, T4 based on the size, and also the extent of spread beyond the line of the bowel, right? Or the bowel. She already said that. I'm not going to bore you about that. And so T1, T2, and that helps us to stage cancer generically. Next one, please. again, the staging. I'm not going to go heavily on this. Just to mention that. So once you have that involvement are involved, then it makes it changes it from early to slightly advanced. That's the key. And the number of nodes can be counted to tell us how many nodes have been involved in the region. And then this is the number of spread. Where is it going to? Is it going to liver? Is it going to kidney? Where is it going to? And lastly here, any disease has gone to the changes. Once nodes are involved, it changes to T2 automatically from T1. Okay. Dukes, we used to use Dukes in the past. It's quite old. I'm not sure if you use Dukes in Nigeria. So Dukes A, B, C, D, and all that. Just correct. So Dukes A will be early, middle, B will be middle, and D is gone. It's fast spread. But I think it's old classification. Please. Next one, please. Okay, this is so. Okay, so the reason why I brought this slide is to show you the quality of the sample that you expect to get. So when you're doing colorectal surgery or cancer surgery, that's what they call the mesocolon. So the mesocolon. So on here, this is followed by this is just the bowel. This is just the bowel, and this is the bowel, and this is the bowel, right? Right, and this believe me, that's appendix there, right? Now, I've taken a lot of the tissue around it. So it's what they call a complete mesocolic excision. Because we know that the cancer will spread by proxy to the adjacent organ. So therefore, the nodes will be here. Now, there's no point in doing surgery and going to tumor that is here. The tumor that is here. You need to take the whole of the organ around it, all of the tissue around it, and that gives you complete clearance. Debulking. Some people use the word debulking. The reason for this is that the oncologist will look for things like she was talking about extramural invasion earlier on. Nodes, we count the number of nodes that get counted, and to be sure that nodes are beyond 12, because the node will determine whether you need chemotherapy afterwards. And then the other things we need to talk about the grade of the tumor. Is it moderate, intermediate, or poorly differentiated of the tumor? Talk about differential of the tumor. Talk about mucinous. Now mucin is very bad. So mucin means they're producing some jelly-like material called mucin, and mucins are resistant to chemotherapy. So it's nice to know that. And of course, I mentioned about the EMVI. There's a big role for pathologists in colorectal cancer. So therefore, the specimens have to be done in such a way that the specimen is adequate for staining. Some people say I've had recurrence. Yet have recurrence. That's the answer. People get recurrence because they're poorly staged, or they're poorly done. You haven't taken the whole of it because they're not trained to do that. And also the pathologies are important to help us in staging. Next slide, please. The reason I put up this slide is because you can look at this tumor there. Around here is a stent. So what we do, I'm sure you have here in England as well. I know that Dr. does some stenting. What we do is that somebody's coming up obstructed. We know that emergency surgery is not outcome of emergency surgery versus a planned surgery. Semi-elective surgery is far better. So therefore, oftentimes we don't rush to operate. More so, you don't have somebody who is trained. Somebody coming in as an emergency at night, we want to open them up straight away. But because we want to give minimally invasive technique, so we stent the patient, put a stent in place. Does one, relieves obstruction. Sorry, I can't say the stent, but stent is there. Trust me. I wish I open it up and then the stent is just something like that. And the bowel of the lumen is narrowed, so just expand it to allow movement of food substance. So that does it does palliate the patient. They give you time. There's no rushing, because at night, we know very clearly that day and light, the outcome is better when we do a planned operation. So the stent will give opportunity to plan the operation. Number one. Two, it allows you as somebody who's been trained to do it. So for example, if there's a doctor or sister is not around, that's one of the MO, somebody's not around, there's no point rushing to go and do the patient. So you can stent the patient and wait to the following morning. Number three, it actually allows you to give chemotherapy, because we know that chemotherapy for somebody who's got advanced disease helps to shrink the tumor down. Deals with the surrounding nodes around here, right? And then and then you can then give you. So the focus is not rushing. So the focus is not rushing to operate. So focus is thinking of how best to get it right. Best to get it right. And I said you would. I was telling them, Doctor, 2 days ago, get it right first time. That's what he get it right the first time. Get it right all the time. That's what we do all the time. That's the acronym. There's always the first time to get something right. There's no point in doing over and over. There's no point in doing over and over again. So you don't taking some tumor out, and then they're taking some tumor out to go back again. There's no point to do that. So you think of getting right first time. So this person's got cancer. My uncle, my relative. How can I give this person the best outcome? The first thing is the first operation is always the best. When right to do back again, over and over again, will not give you good outcome. So that's the whole idea here. Options. So if you've got an advanced tumor, T4 or T3 tumor, what can I do next? Sometimes you may have to do a stoma. You have to rush. So the stoma is a diversion. So there's a blockage along the line. If you go back a little bit, go back to 3 slides for me, please. Where I have anatomy. Of the go back. One more. So if there's a blockage somewhere around here, you can bring out the small bowel as a stoma. That will divert the patient. And then it gives you time to give chemotherapy. There's no rush. It's not that right? It's not a race. It's not like you're doing Formula 1. There's no race to be the first to do it. The rest is about the patient. Think about the patient carefully. Think about the options. Do I have the facility to do this person and give this person a minimally invasive approach? Now, the whole idea of minimally invasive approach, Robotic, Laparoscopic, you avoid the big cut in the tummy. That's number one. Because we know that once somebody goes to a big cut in the tummy, they affect their breathing and they will need to be ventilated. Ventilated equals to an ITU. You don't have to go to ITU. Number two, that's number one. Number two, minimally invasive surgery gives a better view. Once you put the scope, you can see the whole of it. See what is going on. You can see what is going on properly. You're not focused on the area. Because once you open somebody up, you can only see a limited area. It gives you a better approach to the abdomen, and then you can take out the tumor correctly. The pain control is better, and also is minimal. And also is minimal and do minimal. Because at the minimal of the bowel, it doesn't mean that patients return to eating very quickly. Number four is that the pain is better. Then they ambulate very and they can go easier. Hospital stay is very expensive. So overall, minimally invasive surgery is far better. And also for pelvic surgery, can come to rectal cancer eventually. The nerves for men, the nerves that affect ejaculation, erection, so therefore the role of robotic surgery then come into play. We're discussing robot surgery gives us a better view. The anatomy definition is quite, and you can see the nerve. You avoid injuring major organs. That's the major benefit. So that's the major benefit of having the key message here is that do not rush to operate. If you are a GP somewhere else, you have a facility somewhere, the best you can do is to signpost them to the right places where they can have assessment, where they can have imaging done, where they can be planned and be talked through. Okay, next one please. Okay, let's go back to where I was. Back again. Okay, so that's the main benefit. Okay, so that's the main benefit. I've mentioned about the functioning. If you cannot do a stent, you can do a stoma. You can do a stoma. And don't forget the issue of having trials around. I believe that people in Nigeria who are knowledgeable. So if they have, the Foxtrot trial. The few trials going on. I don't go to trial. But the question is that somebody's got a bowel obstruction. Is advanced. If it's advanced, do not rush to operate. Except it's life-saving. So plan is stoma. Or is think that they may get chemotherapy as adjuncts to their treatment. Next one, please. Okay, this quite heavy. But just walk you through the different options that we can offer somebody who's got bowel cancer. So the bowel cancer, let's start from where it's easier now. Let's start from here. So bowel cancer, so the rectum is divided into 4. You can have lower rectum, you can have ultra low, and mid and upper rectum. If you get the upper rectum cancer, then you give them low anterior recession. If they have upper rectum cancer, you have high anterior recession. It follows the name. This is very controversial. This is very controversial. I won't talk about it. Sigmoid colectomy. I don't do it. I believe that if you've got a cancer in the sigmoid, you must treat them as if they have cancer. Because sigmoid is more like the distance between the arm and left colon. And if you have a around the splenic area, you do a left hemicolectomy. If you have a tumor around between the appendix and the partiflexion, you do right hemicolectomy. If the cancer is quite low in the anus area, there's no point trying to do any erase of the cancer. Just take out the cancer, close up the anus, and give it a bag permanently. If they have multiple cancers in the colon, either have one here, they have one there. It shows the colon is unstable. It's unstable colon. It's unstable colon. Then you need to take out all of the colon. the cancer is in between the two, and you want to joining them back later. Think of joining them back later. You can do subtotal colectomy. Total colectomy you often done with people that multiple cancers, and then extended right hemicolectomy is done when there is tumor in the transverse colon. The whole idea is that you need to take enough vessel around and all the fat around. Next one, please. Okay, now I'm not going to go on this again. I'm not going to go on this again because Dr. James and the rest have covered it. The key thing, go back again. The key thing I want to mention here is that PET's been spoken about. PET is very good. PET is very good for monitoring progression. Some people get recurrence after treatment. You're not sure where behavior is similar because we know cancer follow pattern. For example, paired organs go to paired organs. Somebody got cancer in the prostate, it's probably going to go to lungs. Somebody got breast cancer. Somebody got breast cancer, it's paired organ. They also go to paired organs. Does that make sense to people? And doing ultrasound scan here is early rectal cancer. And the whole of the idea is that we want to pick cancer early. Right. There's no point trying to have advanced disease. It's a waste of time because the outcome is poor. No matter what you do. If you have early rectal cancer, picked up on colonoscopy, then how to treat early rectal cancer, and it's completely different. Next slide. Talk about. Actually before then. One more. Sorry. I think back. No, I mentioned forward. No, sorry. Go forward, please. Sorry. Now this one. So histology. There's a lot of things talk about. Things are getting more advanced now. Colorectal cancer. What about MSI, satellite instability, and also mismatch repair. And these are the things that tell us. So for those who are doing this gone. So I'm talking about MMR, immunochemistry staining, immunotherapy in the patients who are MMR instability patient and do benefit from immunotherapy. So you can ask oncology questions. Next one. Okay. So this slide just basically shows you all the techniques you can do for early cancer. Now the whole idea is to preserve the organ. The rectum is very important. If you remove somebody's rectum, that means that their pooing is affected. If somebody's rectum is removed, no matter how well you do it, it's going to toilet like 7 times a day. So in a meeting now, with a meeting like this, somebody will be rushing out of there to the bathroom to have because the rectum is gone. Because the rectum is the reservoir. It's able to store, and your brain has a feedback mechanism to tell the brain, I don't have to go now. I'm sure all of us can do it. I'm sure all of us can do it. Yeah, safely. Out of back and forth. So the whole idea is assumption, right? So the whole idea is that the rectum is so important now that we're thinking of organ preservation. So you want to preserve the rectum. Somebody's got an early rectal cancer. So there's a cancer here. This is one of my patients. This is one of my patients. There's a cancer here. And I've gone in to do what I call tummies. I'll remove this tumor. That's a tumor there. Pathologist. That's what left as a raw area, and I've closed that back. So the patient can actually go back to toilet as per normal. This is how we treat early rectal cancer. Somebody's got early rectal cancer. You should not have to offer them big operation because we are moving towards organ preservation. So I'm just going to run through this very quickly. So the technique we have is so for T1 and now once it's a T2 is still early. Once the node get involved, it becomes advanced. That means they miss the standard operation. You have to give them standard operation. If the T1 disease, you can then offer them excision of the tumor. And the ways you can do it, because I can do laparoscopic. TAMIS just means transanal minimally invasive surgery. That's what it means. Or I can do TEMS. TEMS is transanal endoscopic minimally invasive surgery. I can do TAT is when the tumor is very low, and I can excite the tumor from outside, and then I can do robotically. These are the platforms that we use to do different things. Just on the show. So early rectal cancer is treated for those who are also in the room. Early rectal cancer, you do an MRI scan, ultrasound scan, and you have early diagnosis as early. Please think of organ preservation. You don't need a big operation like we do for everybody else. That's the next slide. Okay. So rectal cancer has been talked about by Dr. James again. I think the emphasis here is that there are all the things you need to look out for. So one of the things the things we look out for here is different. It's different to colon cancer. It's different. Okay, it's different. Don't dabble into it. If you don't know about it, don't dabble into it. Early rectal cancer is differently treated to late cancer. The CRM, so which imagine you picture on that earlier. I'll show you a picture on that. And EMVI. These are the things you need to look out for when you are staging. The key thing is the pelvic side wall. Once the person has a pelvic side wall node involved, then it becomes beyond TME. Advanced. Don't dabble into it. Get somebody else who knows what they're doing. The organs involving like corresponding organs, like similar vesicles. Do dabble into it. Or the ureter. Next slide, please. Okay. Again, back to the TME I was talking about. So this is the schematic diagram of the rectum. And the envelope, the black line. So the black line you're talking about is this line. And that's the rectum. That's the mesorectal fascia. Right. And this is very important to us. We have to be sure that we can stay safely, move the tumor on here. If the tumor goes out into here or touches the line, it changes the management. You have to give them chemotherapy. Or radiotherapy to do that. If the tumor then goes to involve nodes around outside a tumor. Now, if the tumor, this is what they call it. That line. Right. That line from here to here is not anal. Is that the rectum hands around here. If the tumor goes around here, it's very specific knowledge that you need to handle this. So standard treatment is total mesorectal excision. We can also come back to sphincter sparing. The whole idea is that think about somebody who has cancer around here. And these are the sphincters, sphincter muscle here, internal sphincter, external sphincter, are the control the opening and the close of the bowel. So you have to think about is my surgery going to affect the sphincter? There's no point doing a beautiful surgery and the person is incontinent. There's no point. So think about that when you're operating on the patient. And then like I said later on, the CRM or the mesorectal fascia, that's what drives what we do. You must ensure that this is completely taken out. Okay. The other thing to talk about here is organ preservation. Now the newer TNT, just referred to total neoadjuvant therapy, is a treatment that we have available now that will melt cancer away. And so people are now beginning to opt for this treatment, particularly for low rectal cancer. We're trying to preserve the organ. Because we're trying to preserve the organ. But the question then comes, what do you do after them? So it melts away. How long do you follow them? And there's so many issues with it. I'll watch and wait. So that's what I thought. Watch and wait. So you treat them with chemotherapy and cancer melts away. What do you do with them? Do you just follow them off, or do you offer them surgery at the same time? It's all about patient-doctor discussion and see what you want to be done. Avoid surgery in responders. So somebody is responding well. They say, you know what, I want to watch and wait. What you do is do an MRI, scan 6 months, flexible mobility 6 months, check the marker 6 months, and see whether the cancer is coming back. And that's the whole idea about watch and wait. Next one. Okay. So this talk again emphasize. I think what I'm trying to do today is to tell us the bottom line is that rectal cancer is not the same as colon cancer. If you get any of my messages, management and it's all being tailored. So don't bore you again with details here. So the rectum is about 18 centimeters in length, and so you can divide the rectum into two. So you can have that's the anus, low rectum, mid rectum, upper rectum, and the treatment is done differently. So for low rectum, right, the whole idea I think of TNT. Try to preserve the organ. Don't be in a hurry to take out. For mid rectum, yes, you can think of radiotherapy. Radiotherapy has its own side effects. It affects the bladder function. It affects other organs. So think about that very carefully. It's like quite heavy, and there are quite a few trials going on in support of these different approaches. I'm not going to bore you with this detail. The next slide. So the main issue now, the reason why we're having this conversation is that we don't want to get here. So once colorectal cancer spread to other organ, surgery is not the best. Don't be deceived. Once it goes to the liver, the next step of action is to do what they call systemic control. Control the system. So you have to control the system. And that's done by chemotherapy. That's the standard. Somebody said, "Oh, I can do it." No. You can't do it. Even the cancer is small and it's gone somewhere else. It shows that it's traveled from the blood vessel to the node and it's gone to other organ. Because that means that you should not offer surgery for them. So the treatment option is chemotherapy. chemotherapy. First line, if it spread somewhere else, and it's Foxhole. I don't want to go into all the detail of what Foxhole is. Rectal cancer should also be treated with somebody got rectal cancer and it's a T2 disease. Think of chemotherapy. Because we know that will give a better outcome. All rectal cancer, more than stage 2, like I said, more than stage 2 disease. After surgery, they need treatment. So yes, I've taken the tumor out. It's fine, you've taken the cancer out afterwards. What happened afterwards? Because we know that there's principle called tumor circulation theory. So by default, the tumor is circulating already in the blood system anyway. What we can do is to take out the offender, which is the major cancer, and remove it, and then use chemotherapy to deal with the tumor circulating in the system. Does that make sense? That's how to look at it. So don't be deceived. If somebody has cancer and they remove it, and it's an advanced cancer beyond stage 2, the person needs chemotherapy. And the benefit is about 55%. That's debatable. That's how I put it. The benefit is about 5%. I think it's a bit high. I think it's about 5% max benefit. It helps to reduce the chance of the cancer reoccurring again. Remove the cancer, and you don't give them chemotherapy. The chance is that the person has a 5% chance of the cancer coming back. It's very important to get that. Next slide. So again, Doctor, it's more like a repetition. Dr. James already mentioned about prognosis. The key thing again to mention that the mortality is really 50%. Even where you go in the world, it's almost half and half to still die from colorectal cancer. So I say 90% from stage 1. Which is brilliant. So in 5 years' time, if you stage 1 disease, 9 out of 10 will be alive in 5 years, which is brilliant. But if it's stage 4, so I'll say 10%. So I'll say 10% of them will be alive. So that's 1 in 10 person will be alive with all of the treatment put together, which is not very good. And the major issue is staging. Now, the other things I mentioned again, the other things that we can think about is somebody coming obstructed, bowel obstruction is poor prognosis. Cancer is already spread. If somebody has got bad differentiation, it's poor differentiation. It's changing morphology from the original cancer towards the other cells. It's bad prognosis. Somebody's got perforation and the bowel is very perforated. It probably spreads to the peritoneum. It's bad prognosis. Next, please. Repetition again. I'm sorry. Now, this slide just showed us that all of it is not lost. So we get this a lot. So somebody's got cancer and it's spread to. This is the pelvis. This is the pelvis. Right. And for female centrally is uterus. Yes. And for a male, anteriorly is the prostate. On the side, the pelvic side wall. If the cancer is gone, so it's spread to other organ. It doesn't mean all of it is gone. It just means that they can have more advanced surgery, and it's called exenteration. And this is what I try to do here. If somebody's got cancer that's gone to the liver or to the lung, then they can have chemotherapy to downstage the tumor and then think of resecting the lung or the liver. And then you can go back and deal with the primary surgery. Basically, take a message here is that all of it is not lost. Somebody's got an advanced disease. You don't know what to do. Don't dash the hope. Somebody who knows what they're doing. That's what I'm trying to say here, basically. If the cancer is gone to the side wall, pelvic side wall, offer them the standard operation and also remove the nodes, because we know that the nodes also contain cancer. And lastly, if the cancer is gone to the peritoneum, then we can offer them what they call IPEC surgery. IPEC surgery is you can actually infiltrate the peritoneum lining with chemotherapy and then do cytoreductive surgery as well. Okay, next. So again, that's me there. My team doing robotic surgery. That's one of my sisters. And so basically, what I'm trying to emphasize again here is that you cannot have a good surgery with having a team. That's my anesthetist there. Where's my anesthetist? Looking at figures on the slide. There's something going on there. Blood. If you show that blood, you can see all of that going on. That's my robotic assistant. I go to a stand on the robot, and that's me. So basically, what I'm trying to say is that you need people who are dedicated, who do the same thing over and over again. There's no point trying to do one today and then see one tomorrow. No, you must be doing it regularly to give it better outcome. That's what I'm trying to emphasize. Next page. Now, this is not colorectal cancer. This is anal cancer. Now, it's very common. Doctors start about the DJD and all the likes in anal cancer in our society requires proper examination. So you have to look the finger in. Put the finger in. You put your head. Don't put the finger in. You put your head. That's what they say. So have a look properly. If it doesn't look abnormal, growth to what light, be suspicious. So okay. So again, inner warp is very common in our society. And inner warts, you can classify them to CIN 1 to 3. That's anal intraepithelial invasive neoplasm. 1 to 3. When you get to stage 3, the likelihood of becoming cancerous is high. So examine the groin because once I see node in the groin, it means that it's spread. Because inner cancer will spread to the groin. So examine the groin. Endoscope is a little camera you can put in the back and to have a look and to help to map what it looks like, the extent of it. EUA and biopsy, like the patient Dr. mentioned earlier on in the teaching, is very low. It's very low. It's very painful. This person is very painful. So you have to put them to sleep to take a biopsy to get the result. And MRI scan is mandatory to check what is going on, and then the whole body CT. Now the key thing I'm mentioning here is take-home message is HPV. Hepatitis is very important, and I'm sure in Nigeria as well, there's a big campaign about female getting vaccinated because the same virus also accounts for cervical cancer. So cervical cancer, HPV 16 and 17, 31 and 32, those are the strains that we know that cause cervical cancer for female and also orophageal cancer for male as well. So bear that in mind. So HPV virus is very important. Next slide. No, actually go back a little bit. One more. The other thing to talk about is this is not cancer. This is not cancer. This is hemorrhoid. This is pal, or we call colloquially pal. So it's different. So if you're not sure what you're seeing, please refer to a center like Iwosan where it can be properly assessed. Okay. Next page. Good. Next page. Next slide. That one's good. So anal cancer, most of them are squamous cell. Colorectal cancer is adenocarcinoma. Meaning that the response is to chemotherapy. And what we do is what we call the Niger protocol. Niger protocol is basically a combination of radiotherapy and chemotherapy to look at However, if anal cancer is not responding as progressive, then you need to run the cancer. You have to remove the whole of the anus and part of the rectum to get adequate result. Next slide. Okay, this is important part that we need to all calm down. Now, colorectal cancer has got a lot of factors, a lot of epigenetic factors involved in colorectal cancer. So therefore, there are things we can do to ameliorate or to reduce the risk. Mainly is our lifestyle. Healthy food. Exercise. Talking about aspirin. Actually in Europe now, 7 milligram of aspirin daily over age of 50 to actually reduce risk of. It's not been proven. So don't go and buy one over the counter. Okay. Don't try. But that talks about aspirin being very useful to reduce risk. Exercise. You cannot oversize. It's very important. Very important. Next slide, please. And I got a list of food. I think it's going to be helpful. I got a list of food you can eat. So I think all of us go back to gardening. So let's go back to our fathers in the olden days, where they all have their own garden and do their own vegetable in their backyard. To get your own vegetable grown, fruits, olive oil, grain, our mackerel, our alaron is very good. It's very, omega H3 is very good in that. Cereal, drink plenty of water. Things to avoid. So red meat, smoked barbecued meat. Be careful. Suya, kilishi. Be careful. And the likes. Alcohol, sugar is coming up there. Sugar, and less of processed food. Smoking again is common. Smoking is almost in anything that you talk about. Okay, next slide. I think I'm done now. Good. So that's me there. This is meant to show the role of mentoring and the role of continual learning. So I was in Milano. So these two guys are the biggest guys in Europe. That's Anthony Spinelli, and that's Elon Spin. And I went there for 10 days just to go and see what they do. 10 days, just following them around. Just following. That's Investor Humanities in Italy. So whatever you do as a doctor, a nurse, medical education person, you need to keep learning. Learning doesn't stop. Because continual learning is very important, and that's why I put a slide on there. Next slide. Good. Thank you very much. I hope I've not bored you with my medical jargons. It was okay. It was bearable. Thank you. Okay, I think it's time for question and answer. What do you have time now? What's next? The Q&A. Okay.
Thank you so much, sir, for that detailed presentation. I want to say thank you to all our presenters that came before him. It's now time for, this is the question session. I hope we have all been putting our questions down, maybe on our phones. We're going to collate them and ask one after the other. I'm sure we have so many questions to ask from Dr. Osita, Dr. James, and Dr. Akinfemi, of course.
Okay, sorry, while we gather our questions, I just want to recognize the presence of our oncologists. We've been talking about colorectal cancer, and we have an oncologist in the house, so please let's put our hands together for Dr. Olu. We put your hands together for him. All right, so we can go ahead with the questions now. So and we can check online too if there are people that have questions online. Please, let's take them. Okay.
Thank you very much for the lucid presentation. About 3 years ago at FMC, we saw an interesting case, which I don't know if there's a better way we would have managed. About 25-year-old lady, pregnant, who came with intestinal obstruction. I was the one at the accident and emergency. I did a rectal and I saw a big rim. We felt a big rim of hard tissue, which came out to be colorectal carcinoma. So we're in a dilemma of wondering how to manage. She was 22 weeks pregnant. Unfortunately, we were able to cope till like maybe 3 to 4 weeks and she died. I just want to ask if there's a way to manage such pregnant woman at 25 with rectal carcinoma.
Okay, it's better now. Okay, that's a very difficult dilemma, right? You're stuck between the rock and the hard place. It's very difficult. So rectal cancer, back to my slide, is hard, it's firm, it's likely to be stage 2, 3 and above. Okay, for her to receive the better treatment, she will need chemotherapy. She carry a baby, risk of radiation, chemotherapy, she will lose her baby. So what I've done differently, and I'll show the same thing in the breast cancer as well, is that we counsel them about how to, which comes first, egg of the chicken. Which is it? Is it chicken? Is it egg? I think it's the chicken. Okay, if she's alive, she can lay more eggs. Okay, so my approach will have been to advise her to terminate the pregnancy and then treat a rectal cancer with the hope that she can have the child subsequently. That'll be my approach. But again, the anti-abortionists and all that stuff here, we can argue and debate differently. But that'll be my approach. Okay. 22 weeks. 22 weeks.
I think this is where lived experience becomes really important. If you had a group of cancer survivors who have gone through similar things, who have since gone on to have children, it really makes a big difference in the team that manages a cancer patient. True. Because they will know that, okay, fair enough, I have to give up my baby to survive, but at the end of the day, I may still be able to have babies. So I think lived experience. In things like this, it's so important to have patient representation. Otherwise, we're all sitting here patting ourselves on the back, feeling very cool with ourselves. Meanwhile, the people you're trying to help don't feel part of it. It has to be co-created. It has to be done in a way that when we're talking, people are understanding, and it's being fed back in a way that the patient can now absorb, understand, and utilize. So it's really about co-creation and really involving lived experience in talking to patients so they don't feel alone. There's this divide between patients and doctors, where doctors are up there, I'm a bit embarrassed, I don't want to talk to the doctor. Whereas if there's somebody else they can talk to who understands, I think we'll make a lot of progress in terms of patient-doctor relationship.
Thank you. That's very key factor bringing. So in the UK, we have a lot of forum for patients forum who have had similar experiences. So if you go on the website, you have colorectal cancer patient forum, you have bowel cancer forum for patient-led forum. breast cancer patient-led forum. People have lived with stoma, and they help you to demystify. And it's actually, you find a comrade, somebody who's gone through the same experience in the past. It makes life a lot more easier for you. If I'm going through a difficult time, same thing in life. Somebody's gone through divorce. There should be people who can support them going through that. Somebody separated. There are people that support them. I've lived through it. I'm a living example. And then you can, for example, I was raised by a single mother. I was 10. My father died when I was 10. My mother raised me all by herself, 4 of us. Okay, somebody's a single parent. I'll tell you, that's one in the world. I'm a product of that, and I'm proud to say it anywhere I go. Okay, so single parents can still do well. So parenting by single can still do very well. So yeah, so living experience is so important and so key to what we do in surgery. Thank you very much. That's very important. Any other question? Okay, the guy at the end in Burgundy.
Good afternoon. Thank you for the wonderful lecture. So I would want to know, with laparoscopy, is there any risk of upstaging colorectal cancer?
I don't seem to understand your question properly.
Okay.
Can you rephrase it?
So with laparoscopic surgery,
yeah,
you are working with a smaller space.
Okay.
When compared to an X-lab.
Okay.
So I want to know, with the procedure, is there any risk of causing an upstaging of the tumor?
No. Okay, I get your point. Okay, no. So people think you're working with a small space. So when you do laparoscopic surgery, you blow up the tummy, right? The tummy is blown up with CO2, right? The CO2 then blows up the tummy, and then you have the benefit of having to have this thing on the screen, and it's 3D or 4D, depending on what you have. So you don't have any issue of space. Number one. Number two is ergonometries. Your movement of your hand, you've been trained. I wish I had this. I think I show a slide. Where's my slide? Where's Dr. Mr. Yusuf? I gave him a slide yesterday. There was a slide of showing when I was doing some laparoscopic surgery. You can see the movement. So you train to make small movement, and a fine, defined movement. So your movement is not jagged, and it's precise movement. So if you look at robotic surgery, it's even more precise because the robot is controlling how much you can move. You can try how much you move your hand. The machine will not move beyond that. So it's precise. Okay? So there's no risk of upstaging. The risk of injury, what I was going to say, there's risk of injury to surrounding structures. So therefore, if you're a rough surgeon, you haven't learned how to handle the bowel properly, then you can perforate all the organs around. And that will affect what you do eventually. Okay? Good. The lady in white, please.
Thank you for your presentation. It was very interesting. 2 questions. Your last slide, you talked about foods to avoid, and you talked about pickled foods. Okay. So I'm wondering whether that's because of the acidity. Is that why? Second one, about 5 years ago, I met a GI surgeon who said I should avoid nuts. I have not listened to him, but I'm sorry, I love nuts. Okay. So I need to know, do you know about this? Why?
Okay.
Thank you.
Okay. Well, so let me take us back to the pathophysiology of what happened with bowel cancer. So the bowel cancer, the bowel wall is continually shedding off like a skin. Our skin is constantly shedding off, right? It's being renewed, right? And so the same thing with the colon. The lining of the colon. I could probably go back one of my slides. If you want to go back there, the lining of the colon is being renewed, and believe you me, I personally believe that in African population, in Nigeria, for example, the main culprit, I'm not putting on my slide because it's not scientifically proven. We are working on it. Is diarrhea and antibiotic abuse. I personally believe that our system allows us to abuse antibiotics, right, and also diarrhea. Because just imagine, if you imagine that your bowel is like a grinder, your blender, what's called it, bushy mix? What do you call it? One like the girls use now. What do you call it? Bushy mix, yeah, bushy mix. That's what your colon does, right? So all of the food all the good stuff has been taken away. You know that the heartbeat that comes out after your bushy mix. Is it bushy or bushy? Bushy. Excuse me, can tell I'm not a kitchen person. Sorry. So you can tell that. So the hard part that comes out, the waste product. That's what about the colon handles, right? Are you following my thought? So therefore, after you've taken all the food properly, the nice one is gone out in the small intestine, then the waste product is coming out into the colon. Now, the colon, if your colon is doing extra work, right, trying to still process that hard process, then you're in trouble. But that means that your colon, the rate of multiplication or what they call duplicity of the cell is higher. So you're making your colon do extra work. Does that make sense to you? Because the colon is being the maker of the body, which I believe is God. I don't know what other people believe. The maker of the body, who is God, have done in such a way that there's an amount you can handle per time. Now, if your body is giving your body too much to do per time, like diarrhea, one, there's an issue of acidity in there. Number two is that you're making your colon to work extra hard. And that means that your cells will now work extra hard, and the cells cannot begin to proliferate and go into what they call senescence. I don't want to go into all of that biological details. But then it then means that the cells cannot cope with the amount of workload they've given to it. And that cell becomes immortalized. And once they become immortalized, that means it can be replaced. Then that's the beginning of cancer. So our cells should watch, it's like our skin. There should be a time when the skin should just easily die off and a new one comes on. A new one comes on. So back to answer your question, I'm not an expert in food. What I've given you today is what has been, it's very difficult to kind of pinpoint food and diet and cancer because there are so many, a lot of epigenetic factors that interrelate. So it's a very complex biology, right? But we know that if you allow your bowel to have less activity, right? Don't make it look. That's why we're trying to avoid processed food. Perhaps some of the nuts have been processed over time. This has been proven in IBD. My opinion with IBD, I'm an IBD surgeon. So my opinion with IBD, inflammatory bowel disease, I've asked them to avoid ketchup, avoid tomato puree, avoid mayonnaise, and cook their food from the beginning. Believe you me, the changes is dramatic. The symptom is completely resolved. I'm telling you. So that's the link. That's the link we're trying to establish. That your processed food, your highly processed food, preservatives in there, there's some of them are carcinogenic. And that's, to put it mildly. Does that make sense? Have I answered your question or no? Not quite. No, the vinegar is a preservative that helps to extract oil from a fatty food, right? So it's a bit. I don't want to confuse you with all the detail of the food I put there. But what I'm just taking away message here is that your food, let's try and eat lot more of organic food, home-baked food, and avoid more processed food. And that's my own take-home message. I'm not be able to answer your question correctly, but I think that's my take-home message on this. Anybody else who have anything else to say? There's a lady next to.
Thank you very much for the presentation, sir.
You're welcome.
So, my question is, if there's a transplant recipient that developed colorectal cancer, especially one that extends beyond the mesorectal fascia, you mentioned that such patients require chemoradiotherapy. Okay. So, but this patient is already on like lifelong immunosuppression. Yeah. What's the best course of management for this patient, and at what point does one switch to palliative care? Thank you, sir.
Okay, so I'll start from the end, from the beginning. So I've not talked about palliative care at all today. Okay, so palliative care is a big deal, and I believe in Nigeria as well. I know that in UCH, but they have a big team on palliative care. No, the palliative care does not mean that the person is being left to die. Okay, it just means that we're telling you that this cancer at this stage is no longer curative. So we're doing what they call a best approach to manage it. So people hear palliative, they left him to die. No, it doesn't. It doesn't mean that. So it could mean that the chemotherapy, and thank God an oncologist there, that the chemotherapy can be now refashioned or remodeled to handle somebody's going to die in. I don't like to prognosticate, but we have to do that. So put them on a traffic we use traffic lights to signify where. So you have the green, we have the amber, we have the red. Right, so that's what we use normally. So green means the person has more than 12 months to live, right? Amber means between 12 and 6 months, and red means they're going to die less than 3 months. So if they're going to die in less than 3 months, back to your question, there's no point trying to give them heavy load chemo. Number one, their quality of life is reduced. So the whole idea is somebody is palliative that you want them to have time with the family, right? Time to still enjoy life. I have people who are on palliative chemo who are still going around traveling the world. They still go on holiday. They do their 80th birthday. They do what they want to do. So you need to kind of do an holistic approach to looking after cancer. So get the family involved. Patient care, mentioned earlier on. get the palliative team involved, right? Get social care involved and find out at this point in time what's important to me. When somebody is having a terminal illness, you have to ask the patient first, beyond medicine and science, what do you want to do? So, somebody tell me, at this point in time, my daughter is 6 months pregnant, I'd like to see my grandchild. That becomes the focus. And medicine becomes less of importance. Because at that point in time, what you need to do is give them chemo, every chemotherapy. You're going to knock them off. Knock them off of chemo, and then they're useless. So what's the point? Yes, we have the science, we have the understanding. Or put them through surgery. One of my friends that died here in Nigeria, without mentioning names. And I felt, if they have called me for an advice, I'll tell them, just put a stent in. Stent this guy, and leave him alone. Don't offer him any big operation. Of course, offer him a big operation. Did operation successfully, was an ITU, had aspiration pneumonitis, and he died. Okay? And my friend is a renowned radiologist in England. So what I'm saying is that, to answer your question, that chap, I will ask him, what do you want me to do for you? That's the question. So even in surgery, we bring out options, the alternative surgery. You say, okay, at this point in time, A is important. I can try to give you. So back to the issue of T1 and T2 disease. Okay, people who actually opting for T2 now, and I'm saying T2 disease, but give me radiotherapy afterwards. I don't want that. That surgery is mutilating. I just make it look easy. 7-8 hours operation. It looks easy on the paper, but 7 hours operation. Somebody's got a heart problem, who's got a heart failure, who's got this and that. Why don't we put them through that kind of trauma? So surgery is stressful. So back to my question, you need to ask the patient, what do they want from life, particularly when it's palliative. If it's a young patient that's active, then we throw everything at them and say, okay, well, surgery is the option. Let's go to this line, do this, do that. But if somebody is elderly, they've got other issues going on, you ask them what's important to them, and then they will tell you what they want to do. Have I answered your question? Good. Okay. I guess somebody else got a question somewhere there. Okay, after you.
All right. Thank you very much for your presentation. I'd just like you to please throw a bit of light on the use of FIT as a screening tool.
Okay.
In your experience, for people who have used FIT screening, and I did hear the threshold, which is greater than 10.
Yeah, well, 10.
Okay, so when you correlate your finding at FIT and when you then do a colonoscopy, what has that correlation shown to be? And then, would you then use FIT as a screening tool? And at what age band? Where would you? Yes, thank you. So
FIT, what's talking about is fecal immunohistochemistry test. Okay, so FIT basically works on checking out for hemoglobin in the stool sample, assuming that the person is bleeding. Okay, now not all cancer bleeds. Okay, so it then tells you that, so if the cancer is in stage 1 to 2 or T1 and T2, they may not bleed. Or if the cancer is in the cecum, which is very large and captured, they may not bleed. So that means that you already create a bias or a negative, false negative, positive in FIT. But what we're saying is screening. Now, what's a screening? So screening is, when you do a screening test, is that you're saying that you're trying to look for a disease in the population that can be treated. There's no point doing a screening that cannot treat it. So look for a screening in the population that can be treated. It's tolerable to the patient. It's easy, accessible. You can interpret the result, and there's cure for it or treatment for it. That's screening. So therefore, if I'm going to screen the women for breast cancer, mammogram is less painful. I know it's heavy on the breast, but it's less painful compared to having to biopsy everybody's breast. Yeah. So in that way, the only product we have now, there's actually a paper came out last year in Lancet. One of my bosses did something on Lancet. We are now using mucus, rectal mucus, to actually test for cancer. Assuming again is rectal cancer. So none of these tests is full proven. Okay. But back to FIT. So FIT is basically looking for blood in the stool, right? And it's got a lot of false negative. Now, in a country where there is money, so it's all about money. So ideally, before FIT came, the government was offering everybody FOT. FOT is very subjective because it tells you +1, +2, +3. That's not really, doesn't mean anything. So people that have had hemorrhoid, they all get positive tests. What do you do? People that have anal fissure, they all get positive tests. What do you do? So I think, in my own opinion, there's no perfect screening tool. So we all have to take our health into our own hand. That's my first opinion, my personal opinion. So if you reach 45, I recommend go and get a colonoscopy. It is safe. Believe me, it is safe. If it's done don't go and get that. I know there are people that are cracks who do it. You see me do it yesterday. I done in 10 minutes. 10 minutes done. Because I've done thousands. Okay, people have done thousands. Not only people have done thousands. So go to a safe place where you can be properly done. So, but number one, because it gives you assurance that the lesion you are looking at, because the whole idea of screening is not to even pick cancer, by the way. It's to polyp. That's the whole idea. People are making a mistake. So if you do 100 colonoscopy, you pick 3 cancer. That's pick operate. It's 3 out of 100. So the whole idea of doing screening is not to pick cancer. We miss the boat. You miss the boat. You only miss the boat when you get cancer. We want to pick polyps. We want to pick polyps that can be treated, that can be removed safely without having invasive. That's the whole idea of giving polyps. Number 2, you also want to be able to show that there's no other thing else going on in the bowel, like IBD, which is also a killer, but we don't talk about it in Nigeria because it's not very common. So back to your question, the figures then correlate. So if your FOT is more than between 200 and 400, the likelihood that you have a lesion in your bowel is high. It doesn't mean you get a cancer. So if you do FIT and it's more than between 200 and 400, then it shows to me that you likely have a bleeding lesion in your bowel. Now, it may not be cancer, it could be other things that's bleeding. Okay? So that's the whole idea of FIT. So it just makes it to, and also because we try to ration resources. There's no resources. You can't do for everybody. Nigeria is 200 million. So let's say, for example, we want to roll out the pilot study in Nigeria. 200 million. How many of our 200 million are over 40? Let's say 100 million. How many people are trained to do colorectal? How many people are trained? Even in the UK, in the small UK is 65 million. 65 million. How many people are trained to do coloscopy? The waiting list is crazy. It's crazy waiting list because we offer for everybody over 50. So the whole idea of now again. People now come back and say, but I did my FIT last year, it was negative. How come this year I have bowel cancer? Because FIT has got false negative result. Okay, so the key thing is a change in bowel habit. So the change in bowel habit, I'm going to emphasize again, is the change we're talking about is that if you go, bowel habit is very interesting. We all go differently. So some people are early in the morning, by 7 o'clock, they're all in the toilet, and they're done. That's all for the day. Somebody goes in the morning, they go in the evening. Some people go twice a day. Some people go 3 times a day. But if there's a change for you as a person, individualized, then you need to get concerned. So if I was going once daily before, now I'm going 3-4 times a day, you need to wonder what's going on. And if it goes on for like 6 weeks, you need to get it checked out. So the pattern must continue for at least 6 weeks, 4 to 6 weeks, before you can say there's a change in bowel habit. Because here we eat a lot of spicy. My friend was asking me earlier on, is it spicy? Is chicken spicy? I can't handle spice. Any spice will send me down to the toilet. So I can't handle it. So I can't say that's not changing bowel habit. So you have to be consistent over 4 to 6 weeks. Okay, good. Yeah, go on, please. We're here for you. Yeah.
Organization. Okay. And then I have a data that's seated before me. Out of 4,000 people that have screened, or 5,000, I have 900 and something showing up with GIT symptoms. And then I profile that into the upper GI and the lower GI. And I'm still seated at about 300 or 400. So where I got stuck was, okay, so now I have about 400 people. Is it realistic? I've already done colonoscopies for everyone above 50, right? And then anyone who had a positive family history of cancer, of colon cancer in their family, were screened. And we caught some people with polyps, and when it was checked, there was dysplasia, etc. Okay, so what do I now do with this 400 plus? My question, am I then going to an FIT because of that's why I asked that question, the false negatives, or do I subject all the 400 to colonoscopies? Because they're all showing up with either a bowel habit or they're saying something. But I think in my questionnaire, I didn't cater for the 4 to 6 weeks. Okay. I just asked in the last 2 weeks. So maybe that's another improvement. So just asking what would be the next step.
So the question is,
thank you.
The question is, who do you work for? How rich are you? That's the question. No, so because the issue is so if we say that, so in figures it's very interesting in life. So we say let me give an example of one example that's very common. So if you're doing a pelvic surgery, the chance of the person having, are you following me, ma? So if you're doing pelvic surgery, the chance of the person having injury to the pelvic nerve, either that will cause for a male, that will cause rectal dysfunction, ejaculation, or ejaculation is 1%, right? It's 1%. So that means I need to have done 100 for one person to get injured. But I'm not sure that in that 100, what order they follow. It could be my second 100. It could be my second, my 20. It could be my number 30. Are you following me? So it doesn't say I will have done 100, 1, 2, 3 to 100 before I get rectal injury. So the one may occur anywhere. That's number one. Number two, so that person is 100%. So that person, I'm telling you that I'm now having difficulty having sex with my wife. So that person is 100%. So back to your question. So you're looking at numbers because you're probably administrator person. You're looking at your figures and your budget. But the people that you miss in that cohort that you miss, anybody in that cohort that get bowel cancer, to them is 100%. Do you see how to think about it? So that's why I asked the question, how rich are you? So if you're rich like Dangote, then put everybody into bowel screening. Send them to Iwosan. Yeah, okay. There you go. Send them to Iwosan. Bring them to Iwosan. I'll come and do it from England. That's a joke, though, by the way. But send them to Iwosan, and they will do it for you. Okay. Does that answer your question? Good. Okay. Anybody else who have a question in the audience? This is your floor now. I think I've done a good job, I hope. Thank you, everybody. Okay, sorry. No. Okay, go.
There was a time when this, this tablet that you swallow and it takes picture capsule. I think it came into the country about 10, 15 years ago, but it doesn't seem to be that common anymore. How does it take place in your own practice?
So what is referring to is we call it capilloscopy or pill cam. So it's a little tablet that you swallow, right? And then it travels around your bowel. We use it often for the small bowel all the time because in IBD it can't. I was showing Dr. Star yesterday. Actually, I can intubate as much as 20 centimeters of the small bowel through the colon if you do it well. But small bowel is quite long. It's about 3 meters long. Small bowel. So you cannot investigate the small bowel all the way. And MRI scan came in. I think MRI scan is now upgraded. You have T1, T2. Doctor is gone. T1 or T2 signal, and that signal can help you to differentiate what's going on in the small bowel. Now, the capilloscope is good because the video recording of the whole activity in your bowel all the way down, right? The first effect is that if you find a lesion in the colon, what do you do? Well, I can you tell? Still in colonoscopy. So back to square one. Okay? Number two is very tedious. Believe you me, a report of capilloscopy, we actually have somebody who does a capilloscopy report. It takes them, to report one, it takes about 6 hours. Because you have to watch, it takes about, so the capilloscope to travel from his bowel all the way down and to reconstruct the whole of the image takes about 6 hours to do. That's for one patient. Okay? That's the downside of it. Number two, if the bowel is not prepped, you messed up. Because the big issue with capilloscopy is the bowel is not prepped. Okay? And then the bowel is not prepped, you have, because in Africa when you have the kind of food we eat, the high fiber diet, the poo is hard, you can't tell which is which. Or number three, the capilloscope gets stuck. How are you going to take it out? I have a patient who the capsule got stuck, and she said, "No, leave me alone." So I left her alone. She came to see me. Yes, the capsule came to see me, but why it doesn't rupture? It's fine. It's safe. So we left her alone. Then because she got Crohn's, then she came back after maybe like 6 months and said the capsule is stuck, and she didn't want surgery. So I left her alone. Then when she started vomiting, then she didn't want surgery. So that's the capilloscope. So capilloscope is good, but it's got limits. The main benefit of capilloscope is in small bowel, and it's very tedious to report because you have to reconstruct the images, and somebody has to watch a video. You can't watch a video. It doesn't report itself. You have to watch a video to report it. So that's why you should put with them. Okay, good. You're very unique. Interesting thing is that. So they said that to be a good surgeon, you actually watch yourself operate. I've done a number of operations, right? I've got all my videos recorded. I've not watched one. Honestly, I've now gone back to watch one. Okay, I've watched one or two because I published them. Because they're interesting, I published them. They're all on PubMed. Those I know I've watched back to cut them. Normally, I don't have time to watch my video. I'm too busy. I can't watch any video. I'm not that wired up. But it's good if you can watch a video. It's good. Hello, ma. Okay. Maybe 4 hours still. But 4 hours for one patient. That's a lot. Yeah. Okay, ma.
Ask that if there's a family with polyps, grandfather, father, now child, and they don't have any, there's never any cancer. How do they actually find out what their cancer risk can be?
So again, I mentioned the what they call polyposis syndrome, right? I don't want to go into a lot of fine print. So polyposis syndrome are basically people who are just prone to having polyps. There's Jagger syndrome, there's Chuko syndrome, there's so many polyp syndromes that are syndromics. So what we need to do is, if you've got a family history of polyps, get screened. And so what we can do is that we screen the polyp. We can do what they call, there are other ways of looking at polyp that's more high definition, like beyond the normal light, like colonoscopy, which is called the eye scan. There's eye scan. You can do eye scan. You can do chromogram, and the chromogram can tell you the pattern, the change in the pattern of the polyp, and then we can then biopsy those ones and decide what it is. But if somebody's got multiple polyp, Jagger syndrome, they've got all this syndrome, I'll just remove the colon, because you never can tell. You never can tell which of them will become crazy one of these days. And one just becoming crazy after 100 polyps. In short, for FAP, if you count 100 polyps, you have to remove it. You got FAP, you got familial polyposis syndrome. If you're up to 100 polyps, we just say just remove it, because we know that the penetrance is 100%. That means if the person lives up to 70 years, the chance of them having cancer is 100%. So why do you want to wait to that? Okay, good. Okay. That's good. It's good.
It's yeah. We had a patient many years ago who was pregnant. So it's a combination of some of the things we've heard here. She was pregnant, and routinely she was anemic, found to be anemic. And investigations and initially it was pregnancy, vitamins, all of this. But eventually we found out that she had colonic cancer. Yes. She actually chose to have her baby. So she had her baby, and about 6 months later she passed. Yes. Yeah. But my comment is that, what would you say? Because a lot of times we see patients with anemia, and we start them with something, iron. Yes, we do. So what would you say? Because I want to make sure that we sort of take some things, some additional things, at least from my experience. What would you say you would recommend in terms of when you see anemia? Let us say we are all now colorectal people. We are now aware. What would you say? Because I find that we in our hospital, we picked up about 4 or 5 just from random anemia alone.
Let's have class. Okay, anemia class. So anemia can vary into, you can have iron deficiency anemia, non-iron deficiency anemia, right? You can have hemocytic anemia, you can have hemolytic anemia, you can have megaloblastic anemia. Okay, just for the root. Now, the one that we're worried about mostly in colorectal cancer is iron deficiency anemia. Now, if people come to me, so GP referred someone for she's got anemia, HBs. We don't use, you guys use PCV, right? So we use HB, right? So okay, you do both. Okay, we don't use Paxil. So HB is, so for male, right? For male is between 14 and 16, right, gram. For a female is between 12 and 14, right? And HB of the person is 11 for a female, and the borderline for male. And they come to me, and they say, well, they've got anemia. So I do, okay. Anyone with anemia, we scope top and bottom. So we do gastroscope and colonoscope. We do both, because we know the bleeding can come anywhere else. But you're missing the middle part, the small bowel. The small bowel cancer is very rare. It's about 2% cancer. It's a very small cancer. It's very rare, but you can have that. So what I want to do, if the patient is still losing that, so we now look at other signs. So you've got anemia, it's not in isolation, and they got other signs with it. So they've got diarrhea, change your bowel habits. I've done top and bottom. I can't find anything. I look at the small bowel. Then the issue of capilloscope then coming on MRI scan. So you've done all that, and it's negative. What do you do next? So I refer them to a hematologist, because there are other causes of anemia that we cannot fully exclude by doing colonoscopy. So I refer them to a hematologist, and they go and get a bone marrow biopsy. Now you can say that it's an overkill. But again, back to the issue of number. That one person that you miss, they will haunt you. My table is full of complaints. You don't want to make complaints, but even as free NHS case complaints. If you miss one simple thing, they will go to town. They will hunt you down, not because they want to hunt you down. They want money compensation from the hospital. Not for that alone. They want to. Sometimes people have some maybe malicious. Yeah. So therefore, if somebody's got anemia, back to my thoughts, I would like to differentiate them into 2. So things I can do as a colorectal surgeon: is it non-iron deficiency anemia, non-iron deficiency anemia? If they got other signs, then I'll go to town and go all the way to investigate them. If I don't that, nobody can now sue me and say, I've done an MRI scan for you for anemia. MRI scan, OGD, colonoscopy, What more do you want? So at that point in time, I said, you know what, Mrs. Leopard, I've done this for you. I think it's beyond my expertise. I'll refer you to see the hematologist, and the hematologist can take care. But we can laugh about it, but it's serious business. Now, in the lady who is pregnant, and we know that pregnancy and anemia can coexist, and it's very challenging. What do you do? It's quite, some of these are very, they're not classroom taught. There are things that you have to bring the obstetrician into play, and ask the obstetrician to come into play. You bring in psychologists to come and speak to her. She understands the gravity of what is going through. You bring the nurses in. Everybody can now be on the round table. We call it best of interest meeting. Oh, I forgot to talk about that. So best of interest meeting is something we do very often in the UK. So somebody's got learning disability. Oh, Sabala, she's there. Hey, look at me. Okay, that's my UK partner there. So best of interest meeting is a meeting where we can bring it in Nigeria as well. So somebody cannot decide for themselves, either they're elderly, they got dementia. Dementia is on the rise in England, right? Don't assume the family have the best interest of the father. That's the wrongest thing you make, right? The family people have ulterior motive. Believe you me. Some people have ulterior motive. Some people they're after the money, right? Some people are after different things. So once somebody becomes demented, we now have what they call power of attorney. Now, the power of attorney could be two. So somebody can have power of attorney for finances, and somebody can have power of attorney for health. In the same family. Because the father knows who is who. So decide, okay, for my health issue, it will be Tuni that will look after me. For my money issue, it will be BC, right? And then the father has cancer, or the child is got some learning disability, and they got cancer and they cannot decide. And we see that a lot coming now. Because of improved health care, people with Down syndrome and all that. So what we do is do a best of interest meeting. So best of interest meeting is you bring on the table a nurse who's got expertise in colorectal cancer. The family will come, the patient will be there, the surgeon will be there, and advocacy will be there. And that table, with everybody will now say their mind. Oh, my father, when she was alive, this when he was around with his mental intact, this is what the person would prefer. And then we all of that document, and then from that conversation, we decide the best way to look after the patient. It's called the best of care meeting. And it happens not very commonly, but we see that now and again that somebody cannot decide, or we think that the decision of the family is actually not in the patient's best interest. Then we go ahead and do what they call the best of interest meeting. And we call the family member together and they'll make a decision for them. Okay. Anybody else?
Question online on Teams.
Okay.
Yeah. So the question goes as, can you speak about the association with Lynch syndrome, and in your experience, is there association with current trends in the increasing incidence of the disease in this population and the young?
Okay. So Lynch syndrome, right, is one of the what they call HMPCC, right? It is non-polyposis familial colorectal cancer. It's not polyp. Now, Lynch syndrome is genetic. Lynch syndrome, it's about, I don't know the figures in Nigeria, but in England, it's about 2% of the population. So we say we actually have a association of Lynch syndrome patient. And the problem with that is that, I'll tell you why. The problem is that if somebody has Lynch syndrome in the female has all the associated cancers. So the risk of ovarian cancer, uterine cancer is high with Lynch syndrome. So therefore, if somebody has got Lynch syndrome, think down the line that they're probably going to develop ovarian cancer, and I think the chances, if I'm not wrong, I think penetrance is about 60% penetrance of them developing in lifetime. That's huge. So I mean, somebody's got Lynch syndrome at the age of 25, and if you follow them up to their 60 or their 70, they end up developing ovarian cancer. So then it's a big issue of discussion. What do you want to do with your ovaries? What do you want to do with your uterus? So that's why it's very important. In male, it's actually linked with prostate cancer in the male as well now. So male counterpart who have Lynch syndrome, we think of prostate cancer in future. Now, the issue with Lynch syndrome is I've got a lot of patients with Lynch syndrome which I deal with. The issue with Lynch syndrome is that they come in and they have a polyp or colon in the right colon. What do? You take out the right colon. They come back. There's a guy, I don't want to mention his name. There's a guy, my patient, who had 7 years ago, right colon removed, and they are beyond surveillance. So there's registry in England for Lynch syndrome patient. They be on registry. They get a colonoscopy done. So when his father had Lynch syndrome, the polyp was removed and it wasn't cancerous, which is fine. Then 4 years down the line, 3 years down the line, he came to see me. He's got cancer of the rectum. So I removed the whole of his colon and left the rectum alone. And he told me he doesn't want a bag. He doesn't want a bag. Stole my bag. So I joined him back. Took a chance. So he goes to the toilet about 7 times a day. He's fine with that. And then 3 years ago, he developed a nodule in his peritoneum around his small bowel. So what did we do? So we went back to Lynch. There's a Lynch syndrome professor in Birmingham University where I work, close to him, and I get opinions. Somebody said, go and give him PDL oncology is there. PDL2, PDL1. So there's the debate of PDL1 or go back and operate on him and remove the part of the bile. So he decided one surgery. So he went back to have surgery and have PDL, have the direction. While after just finished surgery, he had heart attack. No, he survived. He's 55-year-old, a Greek guy. He survived, 55-year-old. And I'm still following him up to now, doing a colonoscopy, surveying his rectum. So the issue of Lynch syndrome is that the Lynch syndrome is they've got a classic way of presenting, and you have to follow the whole dogma is if you have Lynch syndrome, remove the whole of the colon. But now we say don't remove the whole of the colon, deal with that part of the disease, but be aware that you need a yearly screening. Okay, any more question online? Good. I think I'm tried for this afternoon. Thank you very much.
Thank you very much, Dr. Akinfemi. Please, let's continue with a round of applause. Let's give him a very sounding round of applause. That was beautiful. That was well informed. Fantastic teaching. Thank you so much, Dr. Akinfemi. All right, so now I'm happy to inform us that Iwosan Lagoon Hospital is able to do most of this colonoscopy screen. So we welcome you to come to Iwosan Lagoon Hospital, get screened. If you're here, you have symptoms, or you're above 40, 45, please don't be shy to come in and get screened, okay? Iwosan Lagoon is here to help you. All right, so Dr. Gochuku, what do we have next?
Our Dr. Osita earlier in his presentation was able to demystify colonoscopies. You do not have to be scared of getting a colonoscopy. And from the statistics, you can see that it is very important that you do not run away from your colonoscopy. Please, please get your colonoscopy done. There's so much more advancement in pain management. We make sure you are comfortable. Dr. Akinfemi made emphasis on how much we try to make it painless. So please, let us put that in the back of our minds. Do not be afraid of getting your colonoscopy.
Tell your friends, family, everybody you can get in contact with, advise them to get screened. It is important to see these things to prevent it rather than to try to, go for treatments. So I think that's a very important message we should take out of this presentation.
Another important takeout, please come to Iwosan Lagoon Hospitals. We have 24/7 imaging, CT scan, and MRI, please. And the last thing on our agenda is the vote of thanks. We have come to the end of this prestigious meeting, the Iwosan Lagoon Hospitals Doctors Forum March 2026, Colorectal Cancer Care. And to give the vote of thanks is our medical director,
executive officer, our medical director of Iwosan Lagoon Hospital Ikoyi. Ladies and gentlemen,
please, Dr. Odediran.
Let us put our hands together for Dr. Oyeniran. Please put your hands together for our CEO and medical director.
Okay. Good afternoon, everyone. Thank you so much for your patience and for the engagement. We were having a side discussion just on our table. How many more questions Dr. Akinfemi was potentially going to face this afternoon? But that just speaks to the mental engagement for everybody that has attended. My first vote of thanks goes to Dr. Akinfemi. And I was sharing in a smaller group yesterday. Permit me, he's already smiling. I will share it publicly today. Right, from my very first engagement, my very first discussion with Dr. Akinfemi, within 5 minutes, he basically took over the conversation. And what he said to me, you can't remember the conversation that Akinfemi. What he said to me is, you've outlined 3 things that aligns with my personal goals. I said, what are those? Because I was trying to pitch to him. And then he said, number 1, training. that is obsessed with trading. And I think that's very obvious today. The second thing he said to me was skills transfer. He's so obsessed with transferring the skill he has acquired from all his travels across the world. And I think that again shows in the late interaction he's had with us since Monday that he arrived. I think Dr. Akinfemi is quite interested in teaching other surgeons, in transferring, in building capacity. The third thing he said to me within the first 5 minutes was the importance of multi-clinical team collaboration in patient care. And every single time since then that we spoke, he's always talking about MDTs. Again, that reflected in the conversation this afternoon. So in saying all of that, is just to thank you so much, sir. Because those three things aligns with our goals in Iwosan Lagoon hospitals as well. Thank you for the investments you've put in yourself. Thank you for coming back home with very little, I didn't really have to convince you so much before agreeing to join us. So we appreciate that. Please, let's give him a round of applause for that. Yeah, secondly, I would like to thank the other speakers for today. It was, I think, the notice was quite short for Dr. Jude, especially. Yes, Dr. Jude. Where's Jude? Thank you. Well done. Let's give Jude a round of applause. Dr. Sita, again, thank you so much for keeping Dr. Akinfemi busy within the last 2 days. Thank you so much. We got the message. Now, I'm a bit encouraged about the colonoscopy. Not the way you said it, but again, several of us are encouraged to think about it. Dr. James is no longer in the room. When Dr. James, before she came, so we had this dry run yesterday in the room. And before Dr. James came on the call, I was telling Dr. Akinfemi to say she's the absolute best. Right, so she joined the call and then she did a dry run. And then he whispered to me immediately, Dr. James left the call to say, no, she is indeed the absolute best. So we are indeed proud to have Dr. James. She's no longer here. So thank you to our presenters. Thank you to everybody that has come in to participate, our staff, our partners, our friends, our corporate clients, people online as well. A couple of names have been mentioned this afternoon. So thank you so much. Again, for the patients, I think there is some takeaways at the end of the meeting. Please don't be in a rush so that you can take your stuff to go. Please, Dr. Akinfemi is still with us physically for some time more. If you need further engagement with him, he's very available. You can call us, you can mail us, you can come physically. And even virtually when he's not physically here, he's very reachable. Because we've kind of plugged him into the Iwosan system. And I was telling Dr. Aluko just now that it's permanent, it's not something temporary. Last but not the least, I'm going to thank the leadership of Iwosan Lagoon Hospitals, Dr. Kiro, Dr. Odubara. Thank you so much for always being available, even as we think about doing all of these things. And to staff of Palon, staff of Iraqi Hospital, within the Iwosan healthcare systems, I say thank you, everybody, for making this a successful afternoon. So I'm going to drop the mic here, and I say have a very good evening, everyone. Thank you.
So please, if you are interested in taking pictures with Dr. Akinfemi, please do wait behind.